Well, happy Friday, everyone, and happy St. Patrick's for everyone out there that celebrates that. Um, Welcome to Conversations on Care, a Facebook talk show bringing together our healthcare partners, our clients, our caregivers, all in the effort to help families better understand and cope with aging parents with chronic care needs. My name is Julie Collada, and I'm the founder and CEO of Open Arms Solutions. And Open Arms is a home care agency serving the Chicagoland area, focusing on inspired home care solutions for seniors with chronic conditions such as dementia, Parkinson's, and other movement disorders. It is truly our mission to help our families through this difficult journey and know that they and their loved ones are living their best life possible. If you find these dialogues helpful, please give us a like and a share so that it can help reach more people who need this information. If you have any questions or topics you'd like to learn more about, please write them in the comments below. We'll be checking to be able to answer your questions. Well, with me today is Ellen Hoeksta, Community Educator for AccentCare Hospice and Palliative Care, formerly Seasons Hospice and Palliative Care. And our topic today is hospice myths separating fact from fiction. Hi, Ellen.
Hi, thank you so much for having me today.
Thank you so much for joining us. This is such an important topic. You and I were talking before the live just started, and I'm thrilled that you're here to discuss and have our audience hear this important information.
Thank you.
Can we start off, please? And Ellen, would you share your journey, your personal journey in terms of, how did you end up being a community educator for a hospice company like
Sure,
Accent?
yeah. Thanks. I always knew I wanted to be a nurse. And if you could have told me in nursing school, I would be up in front of hundreds of people talking about hospice, I would have said, really, seriously? But I think that, I worked open heart ICU, I worked neonatal ICU, and I did see a lot of suffering and death, and have my own child who went through treatment for cancer as well, who's doing great,
Oh,
but also saw it there. And just, it's my passion, and it's amazing to be able to help our patients and families.
thank you for sharing that.
Hmm.
I learned something new about you. So thank you for sharing all of that.
Sure, sure.
Uh, so I think, maybe start out, I would imagine we know a lot of people know what hospice is, but let's not assume. Can you share with the audience what is hospice?
Sure. Before I do that, can I share? We always say everybody who works in hospice has that special story. And I have a special story that really is part of my history and why I'm here. So,
Please.
like I said, I knew I wanted to be a nurse. And when I was 15, I wanted to work in a nursing home as a nurse's aide. And back in those days, we didn't have to be certified or any of those things. And I kind of fudged on my age a little bit, but my mother thought I was mature enough. So I was 15 years old, and it was my first day at the nursing home. She dropped me off, and it was very chaotic there, and they had forgotten I was starting to work that day. So they said to me, we don't know what to do with you. And they said, but we have a resident down the hallway and she's dying. And how about if we just go have you sit with her? And I thought, oh, I'm going to run out of here, right? I'm 15 years old, my first day. So they said, she's 103 years old
Mm,
and her name is Hattie. Well, I know I was meant to be there that day because my grandma's name was Hattie, which is
mm,
very unusual.
yes.
So I went down and I met Hattie, this tiny little beautiful woman, And I sat by her bedside and kind of instinctively, I think, held her hand and rubbed her hand and let her know she wasn't alone. But the entire time I sat there with her, holding her hand, I thought, why am I the only person here in the world to witness her passing? There were no family, there were no friends, there was just nobody. And I thought, what if I didn't show up here today? Would she have been alone? And I never want anybody to die alone. And I think I carry Hattie with me, and she lives on through me to tell her story. But I was definitely meant to be there that day with her.
Wow, what a lovely story.
Isn't it? Yeah. And she
Yeah.
was lovely. She was
A lovely story, and amazing at 15 years.
Yes.
Would have that experience, number one.
Right.
Be mature enough to really be able to appreciate and take it all in.
Yeah.
And have it, be make such a substantial difference in your direction.
Mm-hmm. Definitely. Yes.
Thank you so much for sharing that.
Sure.
Can you also, explain what hospice is?
Sure. So hospice, I think, is one of the most scary words. I wish we could just call it comfort care, because that's really what we're talking about. And we just simply provide support and extra care for people in the last phases of incurable diseases so that they can live as comfortably as possible. And we do recognize that the dying process is part of the normal living process. And we really want to focus on the quality of life that is remaining. We believe patients and families have the right to know accurately and honestly what's happening to them, so they can choose how they want to spend those remaining days in the most purposeful and meaning ways that they can. And hospice is delivered by an entire team of healthcare professionals, because we not only address the physical symptoms, but the emotional and spiritual needs, not only of our patients, but of our families as well. And you'll hear me say throughout our conversation today, patients and families, like it's one unit. And so we take care of the patient and whoever they describe as their family. So we don't dictate who their family is, but we take care of them and whoever is surrounding them to support them. And unfortunately, there's so many myths that have created such a stigma to accessing hospice. And like I said, it's scary, but you have a team of compassionate, loving people who are there to just help and join that journey and support our patients and families. So while hospice may not be something everyone wants, it's really important to be educated on what it is, separating those myths from the facts, and then you can decide if it's something that you and your family, think would be right for you.
Yeah, that's a wonderful, wonderful explanation. And I will tell you that I got into this industry, didn't expect to, but I got into this industry as a result of helping my mother through her journey, which was a quick ride and journey of 10 months that ended in hospice.
Mm-hmm.
And it was inpatient hospice. And it was that, I was affected by so many people along the continuum of care that made me very motivated to start Open Arms. But I will say that I have a lasting memory way back when it was Midwest Hospice,
Mm-hmm.
and the incredible care that whole team provided to my mom and to us all,
Yes.
from the physician to the nurses to the social worker was amazing. I'll never forget her. To the CNAs that were with my mom,
Right.
to the music therapy, which was, incredibly soothing to all of us.
Yeah.
And our lesson, we're going to get into the myths because I want to make sure we have plenty of time for all these myths, because it's important. It's really important part of helping people understand what hospice is. And I'm looking at the list that you gave me, but the challenge is we waited way too long, right? As most families do. We were just scared to death when we finally heard that H word, as you
Right.
described. Our family could have benefited from it so much more, so much sooner, as I've experienced recently with my closest friends. So let's dive into the myths.
Okay, ready.
Okay. And thank you for providing these. Myth number one: hospice is a resignation to being resigned to being hopelessness and helplessness. Let me read that one more time. Hospice is resignation to hopelessness and helplessness.
There you go. Yes.
Thank you.
And so, what we hear sometimes is when our patients and families elect hospice, that they're giving up hope. And we reframe hope every day. So, hospice is a very realistic way to deal with a fatal or terminal illness. But we offer the hope of dignity, of comfort. So while I can't cure that disease, what we hope in hospice is that the patient is where they want to be, surrounded by who they determine they want to be with them, and to have their pain and symptoms managed. That's what we hope for. And I hope for my patients that if they want to, go out to dinner, they can still do that because their symptoms are managed. Or if they want to maybe watch a whole TV show, right, and be comfortable. That's not giving up hope. It's very realistic, dealing with that disease, and it is choosing that comfort.
Thank you for that.
Mm-hmm.
Myth number two: hospice is a place to stay.
Right. So I often hear, so you're going to take my loved one somewhere. So hospice isn't a place to stay per se. It's a philosophy of providing care to terminally ill patients. And we care for our patients in a variety of different locations. So we go to where our patients are. So a majority of our patients are in their own homes. That's where they've chosen they want to be, or friends or family homes. But we also go to assisted living communities. We go to nursing homes. We happen to have some inpatient units here in Illinois. We have 4 different inpatient units, one in Naperville, one at Holy Cross Hospital, one at McNeil Hospital, and one at Swedish Covenant Hospital. And those are really for patients who have a higher level of care and their symptoms need to be managed at a different level that sometimes we can't do at home. So it's short-term use, but we go to where our patients are. And in fact, we had the opportunity to care for somebody who was homeless, who chose to remain homeless during their hospice journey. That was their home. And so we were able to provide services where that person called home.
Oh, that's amazing. So
Yeah,
you said
it truly was.
they were homeless, and that's
They
where they
were
chose.
homeless.
And so you went to them.
Yes, we did.
Wow.
And luckily it was a warm time of the year that we were able to do that. Yeah.
Yeah, that's amazing. Myth number 3: hospice is only for the last 24 to 48 hours of life.
Right. And as you said, one of the things that I took away from your experience is that we wished we would have known sooner. And that's why I have such a passion being out in the field and educating not only healthcare professionals, but the community, that a lot of people think it's just for that last day. And in studies, we know it is most beneficial because we focus on that quality of life for the final 6 months of life expectancy. And I will tell you, because I do meet with patients and families as well, it is heartbreaking to go to the bedside and somebody is, in the process of dying and may die before we even have that conversation. And so that's why I'm passionate about people having the information, and maybe it's a year or two before maybe they need it, but to have that knowledge of what's there and how we can help out. But again, it is for the last 6 months of life expectancy.
Yeah, I think people are so scared of that word. You said
Yes.
that before, and I know that was my
Right.
personal experience when the doctor said that about my mother. I was like, oh, it was, and then, it's like anything in life, and certainly now that I've been in senior care for 15 years, it's when families have information, they're empowered to do such important things. And
Absolutely.
I know so many of us in healthcare and post-acute care are very passionate about educating people about that.
Mhm. Right.
And uh, and when you have information, you can make choices, really important choices. And in hospice, you can. We've had people over the years that have been our clients, and we've referred them to hospice, who were on hospice and then they came off hospice because they got so much comfort over all the resources being provided
Right.
to them and to their family. They came off hospice because that end of life, diagnosis changed. And
Right.
so to me, that's been very impactful to see. It's like
Yes. And
that person had resources of a chaplain, the family had the resources of a chaplain and nurses and social workers,
right.
and amazing memories around those families that were
Mhm.
educated, made that decision, and then they had all that extra time with their loved
Right.
ones, right?
Right. And we do see people often get better, like you said, on hospice because
Right.
they're not going back and forth to the hospital for some invasive treatments or catching those infections. And it is a miracle when we do see someone who no longer meets criteria for hospice and graduates off. There's nothing better than that to see, and we do see in studies for certain diagnoses, like heart failure patients, they live an average of 27, 28 days longer with hospice services in place. And some of our small cell cancer patients as well, lung cancer patients, have a longer life expectancy with hospice.
Yeah,
Yeah.
thanks for sharing that. I think it's really
Mhm.
important for people to know that.
Yeah.
Myth number 4: hospice is a substitute for the family or the family's care.
So, as everybody can hear, hospice is a very, very family oriented program, and we help the families care for their loved ones at home. So, we provide education on the disease process, on comfort medications, how to give those medications, when to give those medications. And so, again, I will tell you, we have what we call our plan of care for our patients. And that plan of care is not the hospice plan of care, it is the family's plan of care. And so they're very much included in that plan of care. And we're just there to support their journey and to be available. And I think one of the things our families appreciate, and you probably experienced this yourself, was the 24 hours a day support, that there is somebody to call at 1 o'clock, 2 o'clock, 3 o'clock in the morning, if there is a change in condition or if there's a question, or I tell people, if you can't sleep because you have anxiety and you have questions, call. After hours, our phones are answered by nurses, and there's somebody to call. We always have nurses on call, and they can go out and make those visits if need be. Or we have somebody from our life enrichment team, so chaplains or social workers, available if somebody needs to talk in the middle of the night. We're there and available.
That's great. And that has been my experience. And I will say, as a home care company, I don't know that these are one of the other myths, but sometimes, if there's not family member to support the hospice team, then our care team, our caregivers and care coordinators are really the support. And we're there bedside often, and we're monitoring change of condition.
Right.
And if we have questions, we're reaching out to the nurses, the 24-hour support. And so that is just so important.
Right. And I think that's fantastic that you brought that up, because we do want to see that there is a caregiver, because we know our patients' conditions are going to decline. And so again, you're part of that family and that circle that we take care of. And like when we're in the nursing homes or assisted living communities or those memory care units, we're here to support them as well and available to them. We offer bereavement support or grief and loss counseling following the passing. And we've had services in the nursing homes, because it may be a long-term resident who maybe didn't have any family, and that was their family, and they're suffering just like any family member would. So, yeah.
Yeah. So there is a viewer question, and I want to just make sure we get to that. And the question is, what will the therapists and our volunteers do for those in hospice?
So that's a great question. So let's address volunteers first. So part of our conditions of participation with Medicare, or CMS as we call it, Medicare and Medicaid, is to have a certain amount of volunteer hours every day. Hospice started here in the 80s, and it was essentially volunteer services. So we have volunteers who are in the office who help support us with filing and phone calling. They check, we have what's called a circle of care, phone calls on Thursdays to check on our patients before the weekend to make sure they have supplies and medications and see how they're feeling. So our volunteers do that. And then we have direct volunteers who go out. So we have some in our inpatient units, and it varies geography wise as far as availability of the volunteers, but they have to go through a training through it's Medicare's training to be able to volunteer. And so they can't do any hands-on care, but they can visit that patient. And so they may read to them, they may pray with them, they may sing with them. I was what we call a respite volunteer, and that means to give the family a little bit of a break. So it's a shorter time frame, but I would go to families in my geographic area where I had one lady, and she simply wanted to go shopping at Kohl's, but she couldn't leave her mother. And she's like, I'll only be an hour. And I said, you know what? I have the rest of the afternoon. I'm not doing anything. So you're going to be gone for 6 hours. Go out to lunch, go get your hair done, go get your nails done. I'm here. And I really enjoyed, visiting with her mother. So there's a different variety of things that our volunteers can do. But like I said, they do not do hands-on any type of care. And as far as our therapists, so we kind of group our life enrichment, as we call it now. Our chaplains are part of that. They're non-denominational, so they can go and pray, read the Bible, or whatever with that patient, or sing, or they can simply have conversation. A lot of our families or patients say, well, no, maybe he's not religious or whatever, but it's another team member coming in. And it's really important to know that all of our team members are trained in pain and symptom assessment. So if the chaplain goes and sees something that's different or is concerned, they'll call the team director and let them know there's a change or they seem to be in pain, that kind of thing. So our social workers, again, a variety of different activities that they do with our patients and families to help with counseling, just somebody else to talk to. Some need letters for work to be off, on leave to be with their loved one, or sometimes to help coordinate additional services outside maybe our scope, where they do need, organizations like Open Arms to get in some more help. They arrange what we call our respite stays, that where they maybe need a break and their loved one can go to our inpatient unit or any nursing homes we have a contract with to allow the family to have a break from caregiving, which could be very exhausting. So again, not only supporting that patient, but supporting that family, and available to, we call it anticipatory grief work, to work with those families. So we may not be working, that social worker, the patient may not have needs, but that family, and whoever that family is, if it's the neighbor down the street who may be struggling, the social worker can work with them.
Wow. Thank you, whoever asked that question.
Yeah, that was a great question.
That was a great
Hopefully
question.
that encompassed everything.
Yeah, I think I think that was very important for everyone to hear. So we have one more viewer question, so let's get to that. When a patient is in a nursing facility, how often does hospice come to visit that patient?
Right. So that's a really great question. And in the nursing homes, it's a collaboration of care with the nursing facility. So when we create that plan of care, it's with our patient, their resident, the family, and the nursing facility. And so the nursing visits are based on medical necessity. What does that patient need? So we don't I won't quote a number because I don't know. The admission nurse would collaborate with the attending physician at the nursing home and our hospice physician to determine how many times a week they need to come to see that patient. The CNAs typically visit 2 or so times a week, Monday through Friday. And then with our chaplains, our music therapists, and our social workers, it's really based on those needs that patient has.
Great. Thank you for that.
Mm-hmm.
Another great question. So
yeah,
thank you,
very
whoever
good.
asked that question. All right, let's continue with these myths.
Okay.
Hospice is only for cancer patients.
Right. And you wouldn't believe how many people, including nurses, I run into that think our only diagnosis is cancer for hospice. And again, when it started back in the 80s, it was for cancer patients, but soon became any end stage diagnosis. So what's really interesting is most people believe cancer is our top diagnosis. And actually what we're seeing, and I just looked up these stats, the top diagnosis diagnosis that we see nationally across the board is a combination of Alzheimer's dementia, and Parkinson's disease. And actually cancer's kind of down like number 3, which shows you what great strides we've made in cancer treatment and where we need to do much more with those other diagnoses, right? And so think of patients who have end-stage heart failure or end-stage COPD, respiratory kind of issues, stroke patients, end-stage renal disease patients, and so on and so forth. But it's for any end-stage disease. And 2 physicians have to certify that given their diagnosis, their clinical information, they're just prognosticating, we say, or guessing of the limited life expectancy. And people do live longer, as we said, and all we do is we recertify. We continue to look at them, see if they still need us, and document that and recertify. So we don't, quote unquote, kick people off of hospice, but it's a beautiful graduation. And so.
Yeah, it's a thrilling thing when we see it.
Right.
Myth number 6. This is an important one. I will have to give up my primary physician if I elect hospice services.
So a lot of people think, again, I take you somewhere and you can't have your doctor. And in my experience, most of the time, the attending physicians want to refer to the hospice physician. That's really because like I said, most of our patients are at home, our hospice physicians are board certified in the art of palliative medicine, which means pain and symptom management, and they're readily available to the team. So we don't have to wait. We can pick up a phone call if there's a change in condition or I need a new medication. In the nursing homes, it's a little bit different because our physicians aren't on staff at every nursing home there is. And in the nursing homes, we see their attending physician continue to follow. So nothing really changes except for you get all this extra help, right? In the facility that they're in. We always have a dedicated team physician, and we meet about our patients every week and go over what's going on. But again, they're always available. So say we can't get a hold of that attending physician and there's been some kind of change or we need something, we can get a hold of them.
Great. Thank you for explaining that, and that makes sense. Myth number 7, hospice is too expensive.
Yes, I have heard that from so many. Hospice is actually fully funded 100% for Medicare and Medicaid patients. So what does that include? It includes our hospice team, from that physician to we have a team director that the rest of the team reports to. We call our visiting nurses nurse case managers. And then we have our home health aides, the certified nurses aides, the chaplains, licensed clinical social workers, and our board certified music therapist. Then we cover all the medical equipment that's necessary for our patients. So the hospital bed or wheelchair, shower chairs, those type of things, oxygen. And then we cover the meds related to the hospice diagnosis. So if I'm a heart failure patient, there's some thought out there that we discontinue all your meds. We don't do that because you'd probably be very uncomfortable. But it's up to you what you want to take. So we don't make anybody take anything, but we explain maybe if you stop those water pills, you're going to feel uncomfortable. So we pay for those meds and then anything related to comfort. So when I talk about comfort, I don't want my patient to be in pain. I don't want them to be short of breath. I don't want them to be constipated or nauseated or vomiting or agitated. So we provide for those meds. And so that's a lot of of coverage. Now, I will tell you, commercial insurance or private insurance is a little bit different. And I encourage everybody to check their policy because it really depends on what the employer has chosen to buy. So some may not have a hospice benefit.
And these are for people that are not Medicare
Not
eligible.
Medicare eligible, right? So they may be younger and they have this,
Right.
diagnosis. So yes, so I always tell people check to see your own and see what it is. Sometimes they don't cover all the levels of care. And it may be a limited benefit. Just know, and in the Chicagoland area, I think there's over 200 hospice providers now. Just know that we're all Medicare certified hospice providers. And again, per our conditions of participation with them, we all offer charity care. And usually that is for people who are uninsured, underinsured, or undocumented migrants to the country. So we don't want anybody to forego hospice because of the inability to pay.
Thank you for that explanation. Hospice, myth number 8, hospice stops providing food and water to patients.
So I'm very glad we have a few more moments to talk about this because I will tell you, most recently I met a younger gentleman. He was in his 60s. He was outside. He was smoking when I arrived on his porch of his apartment. And he looked at me and said, "You're going to tell me to stop smoking." And I said, "I'm not going to lecture you on smoking, but you're wearing oxygen. So please don't smoke with oxygen, but you can smoke." Then I went into his apartment and he was a respiratory patient, and he showed me his recliner and he said, "Are you going to take my recliner away from me?" And I said, "Let me ask you a question. Do you sleep there?" And he said, "Yes, I do. How did you know that?" I'm like, "Well, I know your diagnosis and I know you probably feel better." So he came on to hospice and he said to me, "So when do I stop eating and drinking?" And I said, "If you want to eat Fannie Mae and chocolates and Fritos out of the bag, go for it. You can eat whatever." So a lot believe that we just tell patients to stop eating and drinking, and we will never deny food or drink to our patients. But what happens is, as part of the natural dying process, they simply don't want it anymore or get too weak to swallow, or, they just don't want it. And I tell people, think about when you've had a cold or the flu, where you simply just don't want to eat or drink anything. And that's how they feel. Often our patients have cravings for certain things, and it can be frustrating because they all of a sudden decide they want something. And then, it takes their spouse or loved one, an hour to whip it up. And then they bring it and they're like, "Yeah, I don't want that anymore." But a lot of our patients want Cokes, regular Coke with the sugar, or those little from McDonald's, those little sundaes and those milkshakes. And often our staff is bringing those to our patients. So we do not encourage anybody, but like I said, the extra fluids, once they can't tolerate them, are going to be making them more uncomfortable.
Important for everyone to know that.
Yeah.
Choosing hospice care means giving up control.
So our patients and families, as you can hear, are in control. They are in control whether they want hospice or don't want hospice, what hospice they choose to select. Once somebody comes on to hospice, it is not permanent. If there is a new treatment or they just simply want to continue to pursue aggressive treatment and go to the hospitals, they can do that. They just have to revoke. If they've selected a hospice that maybe promised certain things and they're not getting those, they have the right to transfer to another hospice. So they are always in control. And like I said, that plan of care is based on their goals and their needs, and we do not dictate that. That is dictated to us. And like I said, we're blessed that we're able to participate in their care.
I think that so many people feel that. So I'm hoping, thank you for, we have one more myth,
Okay.
but it's, I think people, once they understand that, might elect to take hospice care much earlier, as
Right.
you and I both know and we've talked about, is so important. So important for people to know. So thank you for that. The last myth that we have today is hospice care ends with the passing of the patient.
Right. And, we support our patients for, at AccentCare, we support our patients for 13 months after their loved one has passed away. And a variety of different things, from helping with, arrangements to grief support. We do periodic phone calls. During COVID, I have the pleasure of helping with what we call bereavement or grief and loss calls. I think I called about 1,000 patients, families, and so appreciative that we were still, checking in with them. And that 12-month is very hard. All the first are very hard. So we're there to support them through support groups. We're getting now, after COVID, back in person with support groups, but there is always someone from our life enrichment team to talk and help coordinate some of those outside, services that are available.
Thank you, Ellen. So I think great information. I think let's wrap this up with, I'm sure people want to know, if they don't know, how do I find a hospice provider in my area?
And I think this is really important. Like I said, there's so many hospice providers. When I started 15 years ago, there was maybe 100 or so, and now we're well over 200. So I think the first thing I do is talk to my doctor's office for recommendations. And I think the best person to talk to at your doctor's office is probably the nurses, because they will let you know who they have a preference to use and why they use them. And I would ask my neighbors or families or friends or open arms, because you've worked with different providers. And while we all follow the same guidelines, there's certain differences. I will tell you, Medicare doesn't require music therapy. We are very passionate about using music therapy because it helps our patients. Someone who's breathing quickly, right? It can help. They can match how they're breathing and kind of slow them down without medications, or patients who have anxiety. So incredible to watch a nonverbal dementia or Alzheimer's patient sing along with the music, and just that socialization from it. They are board certified, so they have goals of care with their patients. But again, so there's some subtle differences. And like I said, it's really important. This is a huge decision of which hospice to go to, and which one, stands out in the crowd. I would always, what I call, hospice shop, and we have patients and families do that. Our preference is to always meet our families in person, but we can do short info sessions over the phone. But it's really good to sit down with our patients and families in person to provide what our services are. And like I said, and then get a feel for which hospice, suits your particular needs.
Ellen, thank you so much
You're welcome.
for preparing these myths and answering viewers' questions and spending such quality time with us. I know that this information, we're going to try to do the best we can to share this Facebook Live, because it's such great information. I know you're going to share it.
Right.
Everyone who's receives a copy of this, or you've been on live, if you can share this information with your loved ones and friends, it will be a blessing to all of them. So, Ellen, thank you
you.
so much. It's
Thank
been a pleasure.
you. Thank you for having me. And I hope I took some of the scary out of hospice. And it is such a pleasure working with our patients and families. And like I said, what keeps us going is people like you who say, I wish we wouldn't have waited as long. Right.
Absolutely.
Yes. So thank you so much.
Thank you so much. Have a great rest of
You
your
too.
day and great weekend.
Thank you. You too.